pleasure for me to be able to give a lecture to you on thyroid gland pathology, and specifically an alphabet soup of thyroid gland tumors. I always like to begin a conference with a case presentation as it puts things in context. So let's start off with a 40-year-old female who presented with an enlarging right thyroid gland lobe, upon which a fine needle was performed and a lobectomy was done for a 6-centimeter mass. I would like to drive a virtual slide for you. Here is the virtual slide that I would like to share with you of a thyroid gland. You will notice that there is a very well delimited representation to this nodule. There is a background of small adenomatoid nodules as well as chronic lymphocytic thyroiditis. However, as you look at this particular nodule, I think you will see that there is a very well demarcated area that provides a separation from this tumor and the adjacent parenchyma. The capsule is present, albeit somewhat thin in areas, but it is still immediately identifiable as you go around the entire periphery of this lesion. Importantly, as I drive around the periphery here in a very slow and methodical fashion, I think that all of you can see that there is no evidence of any area of capsular or lymphovascular invasion with a well-formed capsule in most of the space. Now, as you look at this particular tumor, you can see that there is a very well-formed follicular architecture to it. A few areas like this show some areas of degeneration, but for the most part, as you look through the center portion of this tumor, you can see that there is a very even distribution and a monotony to the overall size and shape of the follicles. Let's go and look at an area on high power, and the joy of digital pathology allows you just to double-click and see it. Here you can see the nuclear features, and I'd like you just to spend a few moments looking at them, trying to decide whether you think these have the nuclear features of papillary carcinoma. Let's go to another area just as a point of example, and we'll go over here. Again, super high power at 40x, just demonstrating what you can see as nuclear features. I think all can tell that they are contour irregularities. The nuclei are incredibly large with a high nuclear to cytoplasmic ratio with nuclear chromatin clearing. Let's go to one final area just as another option up here at the top, and again show that there is a similarity to the nuclear features no matter where it is that you go in this particular tumor. Having just seen that slide, I hope that you were able to come up with a diagnosis, and reviewing all of the histologic features, I do hope that you considered this to be a papillary carcinoma or potentially one of the variants that we are going to be discussing today. When one thinks of the overall objectives for today, I would certainly like to give current management for papillary carcinoma. What are the trends that we can do differently, some supporting data, and then, of course, recommendations moving forward. If one thinks about thyroid gland neoplasia in general, it is certainly one of the most common endocrine malignancies. With specifically United States data, it accounts for about 3% of all new cancers, or the 12th most common cancer diagnosis. This is an incidence of about 53,000 per year, and I always find it helpful to set this in a context that's a little bit more meaningful. And so this would be one thyroid gland examined every 8 minutes, which I'm sure is sometimes how it feels. While you'll notice the normal age distribution at presentation is somewhere between 45 and 54, any age can certainly be affected. Much more frequently in females than in males, but the thing I would like to point out is actually at the very end, a 98% 5-year survival for all thyroid carcinomas. So if you think about the new cancers, it doesn't really matter what the ethnicity or race is, it is still going to be much more common in female patients than in male patients in general. If one looks at incidence data as well as death data, and this is going out through the most recent SEER data that is available, you will notice that there is a continuously increasing number of tumor cases, and yet if one looks at the very bottom line, which is the dark triangles, you can see that there has not been any significant change in mortality from the tumor. I started working on thyroid gland pathology in 1994, and so clearly I have contributed to this increase in thyroid gland disease over time, but just to show that there is an increasing incidence primarily related to improvements in imaging techniques. The current management revolves around lobectomy or thyroidectomy. In general, most patients have some sort of fine needle aspiration that is performed before they have a procedure. And you will notice that a completion thyroidectomy is done if any of these criteria is present. So known metastasis, extrathyroidal extension greater than 4 centimeters, cervical lymph node metastasis, positive margins, and of course macroscopic multifocal disease. Poorly differentiated histology and lymphovascular invasion I've highlighted because that is kind of an obvious finding, and this is based on the NCCN guidelines that were released as of August of last year. So if you put this in a different context where no completion thyroidectomy is performed, you can see that you have to have every single one of these features present before someone will not do a completion thyroidectomy. And so you can really tell that there is a major bias by the industry, at least in current management guidelines, to do a total thyroidectomy. Over the years, several people have thought about the overtreatment of thyroid tumors and, of course, tumors in general, with an overdiagnosis and overtreatment being brought up in several major publications over time. Specifically, if one thinks about the encapsulated papillary thyroid carcinoma follicular variant category, many have thought that this was a misnomer because so few patients actually died from the tumor. And in fact, in a very large series put out by Dr. Juan Rosai, you can see that with more than 1,000 patients involved, there was rarely a fatality from this particular tumor category. And so it was thought that we need to come up with a different way of utilizing this category. As you know, with the current World Health Organization classification, there are several different variants of papillary thyroid carcinoma, and I'm including the follicular variant and encapsulated variant here specifically, but there are several others that are also included. I will just add at this time that the new 5th edition WHO is being worked on presently and should be released in January of 2022. When I think of the current histologic subtypes, of course, the usual or conventional patterns are those of the occult, the incidental or microscopic tumor category, follicular variant, encapsulated variant, macrofollicular, oncocytic, and clear cell, all being those that are considered to be of minimal biological risk, while the more biologically aggressive variants are those of the diffuse sclerosing, tall cell, columnar, insular, and hobnail, with a few others that can be thrown in for good measure. When one thinks about papillary thyroid carcinoma, I always think it's important to be able to get a context of what it is that you are talking about or dealing with. And so trying to separate it into both the architectural and the cytomorphonuclear features makes for an easy way of being able to separate and distinguish between the tumors. Part of the reason for showing a presentation first about the classic and characteristic features of papillary carcinoma is if one is going to have a new category, it's important first to understand what the old category may have represented. So let us start off initially with the architectural features, and you can see that these are ones that we normally consider: lymphovascular or capsular invasion, a wide variety of variable growth patterns, elongated and twisted follicles, calcospheroids, intratumoral fibrosis, the tincture of the quality or the brightness and scalloping, and then sometimes crystalloids or giant cells present within the colloid. So when I think about these particular features, let's just look at a few of them now histologically to get a better feel for them. Here you will notice in this example, there is a very well-developed skeletal muscle present out here, and tumor is clearly infiltrating into this pattern. This means that there is extrathyroidal extension, and this raises the issue of how to come up with the correct staging. If one sees extrathyroidal extension, but it is not noticed macroscopically, or it is not identified by the surgeon during their surgical procedure, one generally does not incorporate it into the overall staging. So even though there is skeletal muscle involvement here, one would need to correlate that finding first with what is being identified macroscopically or at the time of surgery, perhaps even with radiographic guidance if necessary. So it is very important in this setting to make sure that you understand which particular classification to place it in. One of the major things that we deal with is fine needle aspiration cytology as a preoperative evaluative technique. And you can see here there are 3 different foci where a needle has gone into the capsule and resulted in what looks like an infiltrative pattern. However, when you go on to higher power, I think you can see that there is really a very well-developed post-fine needle aspiration artifact. You have hemorrhage, histiocytes, kind of a linear quality to it with new collagen deposition. And of course, the background hemorrhage with hemosiderin-laden macrophages. So this is a very important criteria for one to look for. There is always a disruption of the capsule, as you can see here, with a very well-formed breach in the capsule with hemorrhage immediately associated with it. And this is a significant finding after a fine needle aspiration. Capsular invasion, when it is present, is very, very helpful. And here you can see that this is with a special stain, with an elastic stain highlighting this area. But I think you will all agree that there is a very well-developed mushroom shape of invasion or infiltration into the capsule in this example. Lymphovascular invasion, whether it is either lymphatic channels or vessels, need to be separated, but I think all would agree that there is a very nice tumor thrombus in this location, filling into the lumen of this large vessel. A papillary architecture, when it is present, is usually complex. There are multiple papillary projections into the lumen, and here you will notice several areas of free-floating papillary structures. This is because it is a very, very complex architecture. And that, for me, is one of the tip-offs. It's not a simple papillary projection. It's very complex and arborizing, as you can see here. Way too many nuclei are present in this particular case, where you can still see that there is a papillary architecture, but significant overlapping and crowding with all of these nuclei present over and adjacent to one another. The presence of a psammoma body is a very significant finding as well, because for me this means that there is evidence of a dead papillary structure. So when one looks at this, you can see that there is concentric lamination of calcium as it is being deposited around a central fibrovascular core. And I suppose one of the ways in which you can prove this is, of course, going to electron microscopy, which I am not recommending you do, but here you can see that there is a very well-formed fibrovascular core in the center, the degenerated and dead nuclei of the papillary carcinoma, and then, of course, the concentric layering out as you go towards the periphery of the calcium. So this also says to me that when I see a psammoma body present somewhere outside of the thyroid gland, in a lymph node, in a lymphovascular space, it means to me that there is metastatic disease or intravascular development of that particular tumor. Acellular eosinophilic fibrosis is often seen dissecting between the follicles of a papillary thyroid carcinoma, and here you will notice these acellular areas. This is in distinction to what one sees with a more fibroblastic background with histiocytes and hemorrhage when there is just a degenerative phenomenon. So this is more of a tumor-associated finding than what one would see with a degeneration. This is mummification, a feature that I have not seen very frequently outside of the setting of a papillary or follicular carcinoma. I think you can see that there is a very well-defined border to this lesion with a wedge shape over here. So this wedge shape is what gives the terminology for the mummification, and it is really a dead cell layer that is just sitting there. And when you go to high power in the adjacent tissue, you would be able to see the nuclear features of papillary carcinoma. So this particular wedge-shaped mummification is not something that I have seen with any regularity in anything other than a papillary carcinoma. Crystalloids, when they are present, as you can see here, and a few of them over here, and another one in this space, are a soft criteria for papillary carcinoma. Now, I think the nuclear features of papillary carcinoma are present in this high-power field. We're going to talk about that in a few moments. But whenever I see this, I always have a sense that I may be debating about a case, and if I am and see crystalloids, they lean me towards the interpretation of a papillary carcinoma. They are certainly seen in other lesions, and I'm not meaning to imply that seeing them alone is a diagnostic criteria, but when I see them, they are helpful. This same finding can be seen, actually, if you think about what goes on with giant cells. So here is a giant cell present within the colloid space. And in this example, it's actually a histiocytic giant cell. So this is not tumoral, it's histiocytes. They would be CD68 positive. But this type of giant cell can be seen adjacent to nuclear features of papillary carcinoma, as you can tell in the rest of this particular field at the bottom. So again, it is not a criteria that is exclusive to papillary carcinoma, because of course you can see it in granulomatous thyroiditis. I have seen it in Graves' disease and some other disorders as well. However, if I have a case where I am having some difficulty in diagnosis and I see crystalloids or giant cells, this is a finding seen more commonly in papillary carcinoma. So now that we have talked about the architectural features, why don't we focus on the cytomorphonuclear features? So when one thinks about these, there is enlargement of the cell where there is a much higher nuclear to cytoplasmic ratio than normally seen. There's nuclear crowding and overlapping, irregular nuclear placement around the follicle, grooves and folds, irregular contours, intranuclear cytoplasmic inclusions, and then of course that very characteristic pale nuclear chromatin that marginates out towards the periphery, sometimes referred to as orphan anenuclei. So when I think about these features, let's look at each of them individually. So first, let's just talk about cell size. I have purposely blocked out the area of the papillary carcinoma just to give you an opportunity to see the nuclear features of the uninvolved parenchyma. Now, let's look at the papillary carcinoma. And in fact, I still have it highlighted. Let me just drop the highlighting so you're able to see it. And that is the full extent of this tumor. So this is a microscopic papillary thyroid carcinoma, just a few follicles in size. But I think if you were to review this and look at the nucleus size over here in comparison to the nucleus size over here, one recognizes that there is in fact quite a remarkable difference in the overall dimension of this cell. And in fact, if you go back to your physics and talk about what is the volume of a sphere and look at 4/3 pi r cubed, you can see that even the most small change in the dimension of the nucleus creates a huge difference in the overall sphere size. So let me put this in a different context. If you have a radius that is only 5 microns, and in general we think of papillary thyroid carcinoma being much larger than this, but this is the size for a normal cell, you would have a 523 volume. However, let's now just double the size of the nucleus. So in other words, I've increased the radius by from 5 to 10, and you can see that there is an 8-fold increase in the overall dimension. So when we talk about size and shape variation, when there is nucleus size difference, one must think in terms of the three-dimensionality, and therefore there really is a huge change in the overall volume of that cell. Whenever I think about papillary thyroid carcinoma, each of us has our own way of coming up with how we are going to diagnose it. But for me, the notion of the phases of the moon is probably the one that is the easiest to conceptualize, because the moon never really goes away, right? We all understand that the moon is still there, whether it's in full phase or half moon or quarter moon or an eighth of a moon or a new moon. And so as I am showing all of these various phases, one still understands that even though there are these convolutions, the rest of the nuclear features are still going to be present. So let's put a papillary thyroid carcinoma adjacent here. And I think you can now see that there is a demilune formation over here, but a very well-formed kind of full nuclear shape over here, while this one is kind of in a half shape. These down here are now beginning to look much more convoluted in their appearance, and yet you can still see that they have the overall nuclear shape. So let's fill out the entire rest of this, and now I think you're able to see that no matter where you look, you really do have a wide variety of features that are seen in the nuclear features of papillary related to contour irregularities. There are way too many nuclei clustered in this particular space, and almost all of them have grooves present within them. In other words, there's a very well-defined groove throughout the nucleus and usually in a longitudinal distribution. So again, if one were to look at this on electron microscopy, I think you can see that that intranuclear groove is actually related to folding of the nucleus, and therefore the groove is actually a legitimate alteration in the contour of that particular nucleus. A very lovely paper was put out by my friend Mauro Papotti, where you can see that the convolutions of the nuclei by confocal microscopy really are very, very dramatic. And so I have put this in, even though I'm showing you two-dimensional figures here, this three-dimensional reconstruction really highlights how a remarkably convoluted and folded the nuclei of papillary thyroid carcinoma are. Intranuclear cytoplasmic inclusions, when they are present, can be an exceptionally helpful feature, although they need to be very specific, where it is the cytoplasm being pushed into the nucleus. Originally, I would have had these 5 colors form the flag for the Olympics, but we know that that is not going on at this particular time. But let's look at that under electron microscopy. And I'm not going to show any more electron micrographs after this. I think the point is taken, but just for you to understand that there is an actual structural component to these particular histologic features that we look for on standard H&E. And so here, if I look at this intranuclear cytoplasmic inclusion, first of all, I can see that there is a condensation of the membrane around it, so it definitely is the nucleus being pushed aside by the cytoplasm, and then the cytoplasmic organelles are very easily identified within this space, which allows you again to confirm that it is a genuine intranuclear cytoplasmic inclusion. The nuclear chromatin distribution is often quite characteristic. This is one that shows a very well-developed area of fine, delicate, even nuclear chromatin. Well, this has been referred to as orphan Annie nuclei, and of course I'm foreign. I didn't know who orphan Annie was, and so thank goodness a strip of various stamps was put out, and here you can see the entire group of all of the comic strips, but I'm going to focus just on the center in this image of orphan Annie and her dog. However, let's just look at the nuclei, which of course are represented in the eyes. And if you go up to high power, which is what pathologists like to do, I think you can all see that there is this incredible margination of the nuclear chromatin out towards the periphery with a central area of optical clearing. And it is in both the dog and the girl. So we know that this is not just a fixation artifact, it is a genuine finding in these particular nuclei. Well, here is an example of those classic nuclear features where you can see that they are very well developed with all of the nuclear chromatin cleared out and marginated out towards the periphery. Now, sometimes the nuclear features of papillary carcinoma are not nearly as obvious. This happens to be a follicular patterned tumor, and I would point out to you that if you look in an area like this, or perhaps over here, maybe even these areas, you can tell that perhaps there is something else going on. And here it is in a different area, just one field over, and now you can see that the nuclear features of papillary thyroid carcinoma are actually incredibly well developed. So there are several people who like to think about doing immunohistochemistry in these particular settings. And so here is an HBME1, strong diffuse cytoplasmic reactivity, fabulous stain. Here's an example of a galectin-3, strong diffuse cytoplasmic stain, fabulous immunoreactivity. Here's an example of CK19, again giving a slightly more membranous or cytoplasmic reactivity and strong diffuse reaction. And you may say, well, why are you showing it in this particular setting? Well, I'm showing it in order to make a point. In more than 27 years of doing thyroid pathology, and I've seen more than 25,000 thyroid cases during that time, I have never once ordered immunohistochemistry to confirm a diagnosis of papillary thyroid carcinoma. I have ordered it for medullary lymphoma and some of the non-epithelial or epithelial tumors that are somewhat rare, and of course to confirm an undifferentiated to exclude other tumor categories. But I have never ordered it just to confirm the diagnosis of a papillary thyroid tumor. And so I think the immunohistochemistry is not really that significant in this setting. Now let's talk about the mutations just for a moment, and you can see that there are several different mutations. Each of these has various prevalences that are reported, and then of course associated with a specific tumor category type. And so I think all of us recognize that BRAF V600E is characteristically seen in classical papillary carcinoma, while the NTRK can be seen in those that have significant follicular architecture. RAS and RET and THADA mutations, even ALK mutations, are seen as well. So what is quite interesting is that we have been able to identify signature matches to what we see histologically, and there is a BRAF-like pattern, which of course is usually associated with a much more prominent papillary architecture, while those that have the RAS-like signature are much more likely to be a follicular patterned tumor. And so we have had a very nice correlation histologically with what we have been able to identify on a molecular level. There are many different pathways that are involved in this particular tumor development, and you can see how the MAPK pathway along with RAS and RET are all interplayed with one another as the tumor goes on to develop. So this now brings us to the meat of the matter, and that is the inter-observer variability that we see with the follicular variant of papillary carcinoma. And I'm going to highlight just a few of these features here for you in this inter-observer variability study. Here you will notice that there were 6 experts chosen from people who do predominantly thyroid gland pathology, although they certainly do other fields as well, but these are endocrine organ pathologists. You will notice that expert number 5 only recognizes follicular variant of papillary thyroid carcinoma for all of the tumor categories, sort of irrespective of what else may be present. However, as an alternative, expert number 6 doesn't really recognize follicular variant at all, and all of these are in fact follicular adenoma. So as you can tell, if you look at each of these 15 cases and how they were reviewed, you can see that there is only one case. This, ladies and gentlemen, is 7% of the time were the experts able to agree in the diagnostic category. And so this is clearly why we needed to have some additional clarity around this diagnosis. And so this is what started out as a review for this particular category. I personally pulled 721 cases, looked at all of the slides, came up with follow-up for these patients who had at least a minimum of a 10-year follow-up. And out of that particular group, you can see that there are approximately 1/3 in each of the major categories of papillary carcinoma, classical, microscopic, and follicular variant, out of this overall cohort of nearly 324 patients. So that led to the concept of the encapsulated follicular variant of papillary carcinoma potentially being able to go by a new and different name. And so if you think about the new and different name that we came up with, non-invasive follicular thyroid neoplasm with papillary-like nuclear features was introduced first at March in 2015. So it actually has been out for several different years, and yet there's still quite a lot of debate around this diagnostic category. It's always nice to know who was involved, so here you can see the glitterati of endocrine pathology all gathered together, and of course, since I'm the one giving the lecture, I am going to point out that there I was hidden in the background. The way in which we came up with the study was to incorporate a number of different patients who have non-invasive tumors in addition to patients who had invasive tumors, and to be able to collect the follow-up for all of these patients. As you can see, there were a wide variety of thyroid gland pathologists with 24 individuals involved representing 7 countries. And then, of course, we also had endocrinologists, surgeons, and even a psychiatrist, a molecular pathologist, and a biostatistician with a patient survivor. So let me just point out, initially I thought the psychiatrist was for us, but in fact this was a psychiatrist to give an interpretation of the name that we were going to come up with and how meaningful that would be for the patient. So with the study materials, 268 cases were reviewed by everyone. They were put into these 2 different groups based on therapeutic options as well as the overall long-term follow-up. And we went through a whole variety of different weekly conferences in order to refine these particular groups. And you're still welcome to go and look at all 268 cases that were incorporated into the study if you would like to. So ultimately, if you think about it, one has a tumor that is a papillary growth pattern with the nuclear features of papillary, almost always associated with a BRAF mutation. And if it's a small tumor, we call it a microscopic papillary thyroid carcinoma, going all the way through to classical papillary thyroid carcinoma. On the other end of this spectrum, one has a follicular patterned lesion without the nuclear features of papillary, almost always associated with RAS mutations, and this is a follicular adenoma if there is no invasion, and of course if invasion is present, it transitions into follicular carcinoma. So this particular new tumor is in the middle, where there is overlapping features. So you have a follicular growth pattern, but the nuclear features of papillary carcinoma, and the vast majority of them are RAS mutated. So the NIFTP tumor is that does not show any evidence of invasion, while when invasion is present, invasive follicular variant of papillary thyroid carcinoma is the utilized terminology. So as you can see, going back now to that mutation and gene fusion evaluation, you can see that BRAF K601E, RAS mutations, and THADA mutations are much more frequently seen in those patients that have a NIFTP as a diagnosis, where you can see I have now put that out towards the periphery. And so if you think about the point mutations that are present, the RAS family is by far and away the most common for the NIFTP group. But of course, THADA mutations and PPAR gamma can also be seen in some of these tumors. So if one looks at the histology of the follicular patterned tumors and tries to match it to the molecular, I think you will see in this Venn diagram there's a very nice matching of the follicular patterned tumors with the RAS mutations being detected. Of course, this led to the revision nomenclature that was put out as a paper in 2016. And you may say, well, what is significant about this paper? So I'm going to talk just for a moment about the altmetric score. So here you can see it's 1270. What is altmetric? Well, it's a measurement of the social media, the social impact that comes from such a paper. And you can see here that it had a score of 1270, which puts it into the top 5% of all research outputs ever examined by altmetric. Isn't that fantastic? It means I'm actually on a paper that was successful. So this is amazing. Now, when you think about it, what do you do? What do you go and look at when you don't know what something is? Well, the first thing you do is you can go to Google, or alternatively, you can also go to the Wikipedia. And so when I think about that, that is exactly what I decided to do. So that very evening, I entered the Wikipedia into the system and put in all the pictures and put in all the publications. And so you will notice the top here says Lester the Investor. That is one of the names I have. Lester rhymes with lots of things, and this is the best one. But just let me tell you that any one of you try to log into the Wikipedia and change the criteria or change the images, I'm going to get a notification and I'll reverse it right away. So let's also just say that, of course, this was included in the new 2017 World Health Organization system publication. This is a note from my dear friend Yuri, who said, "It was difficult, but it will be part of the new classification." Please note also the time that this message came in, at 1:45 at night, just so you know that pathologists in the WHO are often working into the wee hours of the morning, trying to fight for the things that they think should be there. And so, NIFTP is now part of the global scheme of tumor development in the thyroid gland. Let's all enjoy it just for a second. Okay, what are we going to do about fine needle aspiration? Well, the Bethesda system, as you know, has a whole series of different categories. Bethesda 3 is the one in which this particular tumor is most likely to appear, sometimes in the follicular neoplasm or suspicious for follicular neoplasm category 4, and there will be a strong association with the molecular findings. But because of this, there is clearly going to be a change in the risk of malignancy for any of the categories, because now that you have NIFTP as a non-malignant lesion, there is going to be a major change in that. So the only time I can make a diagnosis now of papillary thyroid carcinoma or category 6 in Bethesda is if they are three-dimensional papillary structures and or there is the presence of psammoma bodies. So the nuclear features alone are not sufficient any longer. One needs to have also those criteria in order to be put into the malignant category. Let me also just say that the USCAP had a whole bunch of different presentations on fine needle, both at this year's meeting as well as last. So the story on what happens with fine needle is not yet over. So when one thinks about the criteria for NIFTP, they're divided into major features and minor features, and then of course those that should not be seen or are exclusionary features. And since we're going to discuss each of these in great detail, suffice it to say that an algorithmic approach for this is probably the best thing. And so as you go through this particular algorithm, which we're going to do now for the next few minutes, no matter what you do, if the criteria is not applied, you go to something else. And that something else can be a whole variety of different tumor types and categories. We're not going to talk about any of those on the right-hand side today, but instead we are just going to focus on what you see on the left. And so having said that, let me just put this in a different context. The nuclear features of papillary thyroid carcinoma, a follicular architectured lesion, and invasion versus no invasion. So if you look at this, you can see that there is clearly overlap between each of these particular categories. And so if you actually put in the other diagnostic categories, you can see that NIFTP is really a very small component of other tumor entities that can be seen within this particular group. And so if I were to now fill in the nuclear features of papillary and the follicular architecture and exclude the invasion, you can see how NIFTP is really going to be in a very small component of this particular Venn diagram. With that in mind, let us begin going through the algorithm as we can now. Encapsulated or well demarcated as a criteria. So this means that there's usually a very well-formed, thick, fibrous connective tissue capsule. Sometimes it's thin and attenuated. Sometimes there are tumors that have loss of the capsule and it's partially encapsulated. But just be aware that many times smooth muscle-walled vessels present within this fibrosis will allow you to be able to confirm the diagnosis. So here you can see a very well-formed peripheral fibrous connective tissue capsule, very well-formed fibrous connective tissue capsule separating the tumor from the adjacent parenchyma. Now this is no capsule present here. Actually, there is kind of a very, very thin capsule. I think you can see that there is a very, very delicate fibrous connective tissue, but it is really, really limited. And yet here you can see a smooth muscle-walled vessel. So this would be a partially encapsulated circumscribed tumor that doesn't show any infiltrative growth into the adjacent parenchyma. Capsular and or lymphovascular invasion. So the answer to this question needs to be no. So that means if you have absent invasion, hence the name of non-invasive follicular thyroid neoplasm. So the non-invasive is the first part of the name because that is the most important criteria, which means no capsular, no vascular invasion, whether it's lymphatic or vessel. And so this means you have to adequately sample the tumor. And if you think about adequate sampling, it means that you must completely submit the periphery of the tumor, which is the part of the lesion from the tumor to the capsule to the parenchyma. One does not need to submit the entire center of the tumor in order to be able to qualify. So there are a variety of different processing mechanisms. Here is one where you can see the person is very beautifully laid out exactly what piece of thyroid tissue has gone into which cassette. And then if you look at the features, you can see that there are 4 different sections of this tumor put into a single cassette. And you will notice there is a very well-formed fibrous connective tissue capsule around this. There's a small adenomatoid nodule or background of hyperplasia over here, but you can still see that there is a well-formed fibrous connective tissue capsule with 4 pieces of the parenchyma to capsule to tumoral interface, which is what you're trying to identify. Some people use a jelly roll. This is very similar to what one does with the membranes of a placenta. And I think here you can see this is the capsule, here is the tumor inside, and of course this has been rolled in order to be able to get as much of that periphery view. It does take a little bit of getting used to, but it is still a method of being able to look at what is going on between the tumor, the capsule, and the parenchyma, and is there any evidence of invasion? And of course, there must be no invasion. So if I think about that, let me just highlight a couple of times. Here you can see that there is a fibrous connective tissue capsule over here, and this is clearly an invasive group. It's even in a nice mushroom shape, another area right over here. Another example here of lymphatic invasion, where you have several tumor nodules collected out in this vascular channel, and very, very clearly demarcating that this has gone out into a vascular space. One final example here where you can see that there really is very, very well-formed fibrous connective tissue with this going out into the adjacent parenchyma, and therefore invasion was present. Frozen section. Well, it's not meaningful and it shouldn't be done. So if you think about NIFTP as an entity having a requirement of the entire periphery being examined before you can place it in this category, you cannot do that in the setting of a frozen section, and therefore the follicular variant of papillary carcinoma is probably going to be the best that you can do, making certain that the surgeon understands that NIFTP may be there at the time of final diagnosis, assuming that you're not able to identify an area of invasion on the frozen. So let's now go to the predominantly follicular patterned and or the presence or absence of papillary structures. So predominantly follicular pattern means that it really is a very monotonous grouping of small to medium twisted or elongated follicles, with the follicles being quite monotonous one to another. Now originally we had said that isolated or rare papillary structures can be seen with less than 1% of the volume, But as we saw publications come out about this topic, we realized that in fact you cannot have any papillary structures present in order to be able to meaningfully place the tumor into this category. And so when one looks at this, you can see that there is a very well demarcated lesion over here, separate from the adjacent parenchyma, and all of these follicles look quite remarkably similar one to another. Another example here where all of the follicles look remarkably similar to one another in this particular tumor. And finally, an area again, slightly higher power, showing that all of these follicles, even though there is some slight variation, all look monotonously similar one to another. Now, this is a fake papillary structure, or a pseudopapillary structure. You can see that there are areas of colloid-filled follicles present within what should be a fibrovascular core, and therefore that does not qualify. Here you have a single papillary projection. It's very rudimentary. In other words, this is something that is really, really small and poorly formed. It still should not be present in the tumor, but if you have one or two of these particular ill-formed papillary projections, you're probably still okay calling it NIFTP. However, when you go to an area like this, there are way too many papillary structures in this field, and in fact I'm going to highlight 6 of them, and you can tell that each of these has a very delicate fibrovascular core expanding out into the luminal space. Another example here where you can see that there are way too many papillary structures present here, where they have a very well-formed fibrovascular core as they extend into the lumen. And so this is an important consideration, because the moment you have papillary structures, the tumor can no longer be placed in the NIFTP category. Likewise, here are too many papillary structures. This happens to be an oxyphilic tumor. I'll talk about oxyphilia in a moment, but this is still a papillary architectured lesion and therefore would not fit in. There's some other criteria: the hypereosinophilic colloid, scalloping, internal acellular fibrosis. And these features are the same thing that you normally see in a papillary thyroid carcinoma, as I described earlier in the lecture, where there is very hypereosinophilic colloid here. An example of scalloping of the colloid, where there are bubbles or vacuoles in the colloid as they are immediately adjacent to the tumor. And then finally, you have areas here that show an interfollicular acellular eosinophilic fibrosis, which is so characteristic for this particular tumor category. So now we go on to some of the exclusion criteria, and you will see that some of the exclusion criteria are listed up here with psammoma bodies or other variants, and then of course the presence or absence of tumor necrosis or increased mitotic figures. So you cannot have any psammoma bodies, because I already said a psammoma body is a dead papillary structure, which you cannot have. You can't have tumor necrosis. You cannot have increased mitotic activity, and therefore no other patterns should be seen as a dominant finding in this tumor either. If you have a specific tumor category, it also is removed from this particular group. So here you can see that there is well-formed tumor necrosis. This is way too much and therefore is not going to fit into the category. This is a solid area of tumor, but I'm using it just to highlight that there are 6 or 7 mitotic figures that are present in this lesion, and that is just way too many for it to be considered within the NIFTP category. The solid pattern over here, again, an exclusion criteria, especially if this is the dominant finding. Sometimes if there's only a small portion and the criteria are specific to 30%, but a small portion of it can have a more solid area like this, but if it is the dominant finding, it should not be used. Cribriform morula variant, this is going to be recognized as its own tumor category in the 2022 WHO classification, but at least for now, as a papillary tumor, it would be out. Tall cell pattern, here you can see cells that are at least 3 times as tall as they are wide, arranged in a tram track distribution. And you'll notice there are also some giant cells here, so that's again another feature that helps you with papillary carcinoma. But the tall cell pattern is going to take you out of this lesion. Columnar cell variant is also going to take you out of the pattern where you have subnuclear vacuolization and clearing, so well identified in this example. So finally, we get to the nuclear features of papillary thyroid carcinoma, and that would put you into the NIFTP category as long as all of the others have been met as well. So let's talk about that. This is where you do have specific nuclear features of papillary carcinoma that are separated into size and shape. nuclear membrane irregularities, and chromatin characteristics, with 1 point given to each of these, so a maximum score of 3. However, if you have 2 or more of these features present, it is going to be considered to be diagnostic for the nuclear features of papillary carcinoma. So let's go through each of these individually and be able to point out what the features are so that you'll be able to see them and recognize them. You can see that enlargement, elongation, and overlapping do need to be very well developed in order to be counted as a sufficient criteria. So when I look at this, this is way too many nuclei that are all crowded and overlapped over one another. And again, the nucleus is very large in comparison to uninvolved parenchyma. Now, I'm not showing you uninvolved parenchyma here, but you can use your imagination. Another example of way too many nuclei, nuclear elongation is present here as well. And of course, again, the nuclei themselves are way too large in comparison to normal. The nuclear contour irregularities with nuclear grooves, folds, and intranuclear cytoplasmic inclusions are another criteria. I will say that most NIFTP do not tend to have a very high number of intranuclear cytoplasmic inclusions. So here you will see that there really are contour irregularities. They have lots of change to the periphery. There's folds and grooves, boxcar shape to them, irregular outlines to these nuclei, and that is certainly one of the criteria. Again, a different case here, showing that there is a remarkable variation in the contour. It is quite irregular with grooves and folds easily identified, and again, not really much in the way of an intranuclear cytoplasmic inclusion. The final criteria relates to chromatin features, and this is where there is chromatin clearing, margination out to the periphery, and kind of that glossy nuclear appearance. So here you can see that all of the nuclei tend to have an optical clearing. And let me just point out, as I've done each of these, I think many of you have said, oh, but the other criteria of nuclear features of papillary carcinoma are there. And that is exactly the case. Because in order to be able to qualify, you need to have more than just one of these particular features present. And so as I've shown you each of these, it's very difficult to just show you nuclear enlargement without also combining it with contour irregularities and also having the nuclear chromatin clearing. So it is a finding that sometimes when you look at them, you can see that there are several different features that are present, and therefore it becomes easier to make the diagnosis. However, in a case in which you're struggling, if you just were to look at this and say, is there nuclear chromatin clearing, yes or no? And in this case, I think all of you would be able to say yes, and therefore 1 point is assigned. And then this next criteria of is there nuclear enlargement, and you would say yes, and therefore you now have a score of 2. Whether you have the contour irregularities or not in this case, you would still have had a sufficient number of criteria to put it into the nuclear features of papillary carcinoma. Let me just say that there has been an expansion of NIFTP over the 5 ensuing years since its original publication. Microscopic tumors are now recognized. These are tumors that are less than 1 centimeter in size. In the original criteria, the tumor needed to be at least 1 centimeter. Pediatric case tumors are also now recognized, as well as those that are macroscopic, meaning much larger than 4 centimeters in size. And then finally, the oncocytic tumor category type has also been recognized as a potential candidate within the NIFTP group. So, can you come up with the diagnosis in Mexico? And I think the resounding answer is absolutely. So we did a very nice international inter-observer variability reporting of the nuclear criteria as a validation study. And in this particular group, we took people from the US, Japan, and the UK. You can tell that there's about equivalent number of people from each group. We did a mean number of years of practice, whether they had board certification or not, and the number of cases that they were able to review. And you can tell that there is an equivalence between each of these groups. And so each of these had a kappa statistic assigned for them as to the reproducibility. You will notice that we compared it to the experts because these cases were the exact same ones that we utilized in our study, and therefore I feel that they are quite valid in their classification. So as you look through this, I think you can see that the overall mean is quite good, but you can tell that there is a much closer kappa statistic reliability for the second criteria, which is the nuclear contour irregularities. So this tells me that everyone is able to tell a nuclear groove and fold and contour irregularity much more reliably than the nuclear size and or the quality of the chromatin distribution. However, you can see that the quality of the nuclear chromatin distribution as a single criterion is actually the most reproducible within the group of experts. So apparently, the experts definitely rely on nuclear chromatin clearing out and margination to the periphery to come up with an accurate diagnosis. So the nuclear features were separated between those that did and did not have molecular findings associated with them. Each and every one of the cases was separately adjudicated for each of the groups in order to be able to come up with positives and negatives, and ultimately there was not really a specific difference between the countries or between the number of cases that were reviewed or the number of years as a practicing pathologist, although as you can tell from the lines, there's kind of a trend going towards the longer you've been in practice and the more cases you see, the more likely you are to be able to make the correct criteria. So what it ultimately proved to us from a wide variety of different case review is that there was a final kappa statistic of 0.7. This means that there is substantial agreement, and so this tells me that every one of you in the audience is actually able to come up with the diagnosis and with the criteria that would be possible in this case to come up with the right interpretation. Now, how much of the tumor needs to have the nuclear features? Well, this is not really well defined. That was not one of the features that we addressed, although in the study that I had performed on this case, I wanted to have the features in at least 3 foci per centimeter of gross tumor dimension. So if it was a 3 centimeter tumor, I needed to have 9 foci within that tumor that showed the area of classical nuclear features of papillary carcinoma. And of course, it's all within the same single nodule, even though it may be multifocal or multicentric within that single nodule. So let me just highlight that particular feature for a moment. I think here you can see 2 different fields at low power. I'm going to go to each of them on high power. So if you were to look at this field first, I think you would be very hard pressed to say this is the nuclear features of papillary carcinoma. I would give this a score of 1 because there is nuclear enlargement. However, immediately adjacent to that, here you have an area that shows classical nuclear features of papillary carcinoma, and therefore it is important to recognize that these features are often quite different one field to another. So let's look at the nuclear score here and see if you guys are able to come up with it. So if you look at just these nuclear features and think of what you would come up with in your mind, I'll show you that, based on a point score of 0, 1, 2, or 3, hopefully you had a score of 1 because there is nuclear enlargement, and therefore this would not qualify as the nuclear features of papillary carcinoma, and therefore you would not be worried about NIFTP as a diagnostic term. Let's look at this one. What would you give as a nuclear score for this case? And here I think, again, you can see that there are several features that are easily identified. Let me give you the opportunity to think of them in terms of the point scoring. And I think if you came up with a score of 2, which is what everyone else did, again, you will see that this is sufficient to meet the criteria of NIFTP from the standpoint of the nuclear features. So let me just highlight one of the most important things that all of this particular study has outlined, especially for me. So the name of the new tumor is non-invasive, as the very first component of the name. And so with that in mind, I thought, let me go back just to papillary carcinoma as an entity and just look at the difference in what happens to patients if you look at those that have lymphovascular invasion. So of each of these particular cohorts of patients, you can see that if there is no evidence of lymphovascular invasion, not a single one of the patients had disease, not a single one of the patients developed metastatic disease, and they all had no evidence of disease at last follow-up, with an average of 11.1 years of follow-up. However, the moment you go to the next group, you can see that when lymphovascular invasion is present, now 11% of the tumor patients will have evidence of disease at last follow-up, and these are the patients who develop local recurrence or metastatic disease. So again, for me, the presence or absence of lymphovascular invasion is one of the most single valuable features to be able to document. Of course, the management for these follicular variant patients was with surgery only for the vast majority, without any radioablative iodine as a follow-on, being managed with lobectomy, and you can see that they all had an excellent overall outcome, and therefore the presence of the follicular variant category is very, very meaningful. And if you look at the newly released 2015 American Thyroid Association or ATA management guidelines. Unfortunately, we did not quite have our study completed at the time to be included, but if you look at this particular diagrammatic representation, NIFTP would clearly fall below a unifocal papillary thyroid carcinoma on the risk stratification model, and therefore be something that would be quite easy to manage without any additional therapy. And so with that in mind, if you think about your algorithmic approach in order to be able to come up with a diagnosis of NIFTP, I would like to encourage you to focus very specifically on the criteria, recognize not to overdiagnose that would potentially dilute the category, and that finally, criteria will evolve over time. So this is something where whenever one has a new classification, it's important to keep up with the literature in case there is any further development in the lesion. I would like to thank you very much for listening to my presentation. I would have loved to be able to have been in Mexico live for it, but unfortunately, given our current COVID circumstances, would have to do it from a distance. I am very happy to have any questions sent to me separately if you would like to do so, and I greatly appreciate the opportunity to share with you today. Take care.